Apologize for the fact that we are running a bit behind the schedule, but the last session before the tea break is the Executive Director of the African Palliative Care Association, Dr. EmmanuelLuyirika, a long-term friend and a great speaker. Welcome, Emmanuel.
Good evening, everybody. Good afternoon. It's evening in Uganda, so I'm going through my first shock of winter. You know, in Uganda we live on the equator, the sun never goes away, but it seems in Europe it escapes to somewhere else. I want to thank the Academy for inviting us to be part of this Congress, and also to thank all of you who have been of support to programs in different places in Africa, including Sister, as she has shared. We're talking a lot about what was going to happen in Togo, and we're always grateful for the support. As I stand here, I'll be talking to you about what is happening in Africa. Africa is like an elephant. When you touch the tail, it's tiny. When you touch the leg, it's huge. When you touch the trunk, it's sharp. So Africa is quite diverse. I'll go through an introduction, give a bit of statistics, talk about the key models that have been developed, and then I'll touch a bit of work of the African Palliative Care Atlas that we worked on with our colleagues at University of Navarra, APCA, and Mount Sinai. And then we'll make conclusions and some recommendations in a way forward. But before I do that, I just want to talk to you about APCA, or the African Palliative Care Association. We are a Pan-African organization. We are a membership organization with over 3,200 individual members and over 1,800 institutional members. We work together with civil society organizations, NGOs, faith-based organizations, regional and global agencies, ministries of health, and our objectives are mainly to create awareness about palliative care from the patient level, family level, community, health worker level, academic institutional level, and then politicians and policymakers. We also work to strengthen health systems by integration of palliative care, and then development of research evidence for palliative care within the African context. And the last one is to develop sustainability. We are a continent of 54 countries, over 1 billion people in Africa. You also know that close to 23 million Africans have HIV. Cancer is another huge challenge. The other challenge associated with cancer is that over 80% of the patients in Africa present very late, when any curative attempts cannot even be dared. Interestingly, in a number of African countries, close to 40% of the healthcare services are provided by the churches. So that tells you a lot. With a small budget, they are able to shoulder a huge burden of the health service delivery. With all the efforts going on in the continent, less than 15% of the population has access to any kind of palliative care model anywhere. Less than 15%. And 15% is in the countries where we think things are going a bit better than elsewhere. The only two entities that have reached this population are mainly the church and Coca-Cola. The question is, how can we engage these two entities to take palliative care where they go? There are a number of frameworks that have somehow impacted palliative care in Africa. Much as the palliative care definition by WHO has its problems, it's been very good for us because it has defined the limitations for us and also to engage governments. The one thing that you need to know is that in Africa, when you're going to talk to ministries of health, you need to have something from WHO. If you don't have it, they may tell you, well, this is something that we, so that has been very helpful for us. We also have about 21 countries with national associations, national hospice and palliative care associations. We have some hospices, the oldest being in Zimbabwe, Island Hospice. It was the first hospice in Africa. And on that, we've also had 2 sessions of ministers of health on palliative care. The first one was in Johannesburg in 2013, and the ministers made a palliative care declaration. That was just before the WHO engagement around the resolution. That helped us a lot because then the African ministers were able to speak with one voice at the WHO. Then we had the second one in 2016 in Kampala, and that focused on the WHO resolution and essential technologies. So those are the 2 commitments that they made at that Ministers of Health session. Before that, in 2012, the African Union, like the European Union, the young African Union, made a common position on access to pain medicines. So they have a document that we can take to countries and say, this is what you should use to make sure that you have access to medications. So all these have provided an opportunity for palliative care training, research, and practice. A lot of the work in Africa is based on partnerships, without which nothing would happen. NGOs, churches and church-leaning organizations, other civil society organizations, governments, even though they have come on the scene late, but governments have come in, the World Health Organization, and the African Union, as I've said. So what is our role as the African Palliative Care Association? Focusing on the 4 objectives we have, we support the countries to ensure that they put these, that they push the agenda for palliative care. And one of the things we do is to offer technical assistance to countries on oral morphine reconstitution so that they have access to oral morphine. We've done that in Uganda, Malawi, Swaziland, Botswana, Zimbabwe, Kenya, Nigeria, Rwanda, Malawi, and a few others. We've also supported palliative care policy development. The last one was Botswana. They were able to do their entire policy process in 12 months. And they made a request as we were supporting them to develop their policy. They said they would like to have a provision in the policy where government can support civil society organizations to provide palliative care where government cannot go, or where government is not. Now, that was unique for Botswana. We've also had South Africa develop its, after the last Ministers of Health session, South Africa has also now developed its national palliative care policy. And as you know, South Africa is a leader for us on the continent. They are kind of our reference big brother. So if they have a policy, then that's a good addition to everything else they are doing. We also work with our partners and funders to run a small grants program where palliative care providers and hospices, and at times even ministries of health, can apply for that small grant of £5,000 to do a specific aspect of palliative care, whether it's children's palliative care, a training session. But we do that every 6 months. We have a round of funding for about 8 to 10 small grants. We also offer technical assistance in health systems, in education, research, and also data platforms to our partners in Africa. At the moment, we are also engaged in a specific palliative care advocacy project in Eastern and Southern Africa. And as a result of the ministers' session we had in 2016, one of the donors asked whether we could support 4 countries, 3 of them in West Africa and 1 Portuguese-speaking country, to develop their national policies. And so we are now busy working with the Gambia, Angola, Togo, and Liberia to develop their national palliative care framework. I've talked about the conferences, and I will not overdwell on that, but one key aspect that has been useful is the South-to-South partnership, in addition to the partnerships from outside the continent. For example, Uganda has a very good model for access to oral morphine, and so we get ministers or health workers or ministries of health from other countries to come and visit and go back and implement. The same we are now doing in Southern Africa between Malawi and other countries, which we've also found to be very useful. Having said all that, I didn't want to start on the negative bit. The patient experience in Africa is still very much less than desirable. Majority of the patients have no access to palliative care because of lack of trained personnel, limited financial, infrastructural, and other resources, long distances to the services, and lack of home-based care facilities in many of the places. We also have legalistic approaches to controlled medicines by some of the health workers and some of the control authorities. Little or no financing framework for palliative care integrated in other health financing mechanisms. And I'll pause at this point. One of the reasons why palliative care jumped a bit in the last 10 years is that PEPFAR, which is the US government funding for AIDS, included a portion for palliative care. Now, that came to an end about 2.5 years ago. And that has meant that in many countries there has been a regression because of that shortage in funding. And at the same time, the African governments promised that they will spend 15% of their budgets on health. But none of the countries have actually reached that as yet. So it's a major challenge in terms of funding for palliative care. However, we have some very good models on the continent which can be replicated. We have the South African model where the National Palliative Care Association works very well with the Ministry of Health and the ministries of health in the provinces. And that also supports the hospices in those areas. Then the Ugandan model where you have the government of Uganda buying the morphine powder, and it takes it to the Hospice Africa Uganda, which is an NGO. Then Hospice Africa Uganda constitutes it into liquid. Then the liquid is taken back to the national medical stores for government facilities and joint medical stores for the church facilities, and then the morphine is distributed free of charge. The government meets the cost of the morphine powder and then works with the other partners to make it available free of charge to the patients. Then in Kenya, we have the APCA model, where the National Association, the National Palliative Care Model, works to set up hospices or palliative care units in government hospitals. That means they don't have to pay for infrastructure, for buildings, and at times even the staff might be seconded from the government. So that's another very good model. And then the Botswana model that I've talked about. And then we have Malawi that annually generates a report on the state of palliative care in the country. Whereas a number of countries are weak on data collection, Malawi, even though it's one of the poorest countries, endeavors to generate a report about palliative care on an annual basis. I've also talked about the small grants that go a long way. Let me now turn to the APCA Atlas of Palliative Care in Africa, and that's the team that worked to make sure that it's in place. You can see Professor Carlos, Liliana, and John. John is here. I don't know where he is. John, where are you? John is right over there. And we're having our meeting in Spain as we're talking about launching the Atlas in Africa. That map shows you the countries where information was collected. It was almost the whole of Africa. At least 38 of the countries have some sort of palliative care service when you look at that atlas. Uganda had 229 services, South Africa 160, Kenya 70. But out of all these countries, only 16 had access to pediatric palliative care services, and that's an important point for Joan to hear. Swaziland had the highest number of services per million people of population. Uganda had about 5.9, Gambia 5, South Africa 2.9, and only 28 countries out of the 54 had home-based palliative care services, with South Africa topping. The number of patients in palliative care services, again, there was an issue of lack of documentation, because if you look here, Uganda seems to be doing well, but in terms of recording the number of patients receiving services, it didn't appear at all, because it was not documented. Whereas South Africa, Zimbabwe, Zambia, Botswana had their figures in addition to Kenya. Now let's look at the funding. I've talked about the issue of financing, and I know Tanya has talked about that as well. If you look at health expenditure per capita of the top countries in Africa, you see the figure there. It's not a lot of money, and if you look at the East African countries, Kenya, Tanzania, Uganda, Rwanda, South Sudan, Burundi, it's really very, very little money. Then you have countries that have an existing national palliative care plan. You see the dark colors, either in the cancer plan or in the HIV plan. That's what C is cancer, H is HIV. So that shows you where we are. The one thing you see is that there is a predominance of East and Southern Africa, whereas Western, Central, and North Africa are not very well covered. That's what I've just shown you. In terms of access to national palliative care clinical guidelines, these are the countries that had access to those documents. Again, these are countries largely in Eastern and Southern Africa. The majority of the countries are in Eastern and Southern Africa, and they're mainly Anglophone. Having a palliative care desk at the Ministry of Health, it was a similar issue, but we had this time other countries from West Africa, Senegal, Guinea, Cote d'Ivoire, and then in the north we had Libya. You might be interested to know that at the last meeting we had in Kampala, we had the Minister of Health from Libya. Despite their turbulent times, he was able to come for that meeting. Palliative care education has also gained some ground in South Africa. They can offer at master's level. We have Kenya, Uganda, Egypt, and some activities in Ghana. In terms of nursing schools with palliative care courses, again, we have those 9 countries where some progress is being made. Now, the one thing that you need to know about Africa is that nurses are very important in the delivery of palliative care services. And without nurses, there is no palliative care in Africa, because the doctor-patient ratio is so bad. So when you have your team of nurses, it makes the whole difference. And investment in nurses and making sure they are well catered for, of course, in addition to doctors, it makes a whole difference. Number of palliative care hospices, I've talked about that. In the countries with palliative care, with pediatric palliative care services, again, you have South Africa, Nigeria, Malawi, and a few others. So in terms of medicines, as I've said, we have good models on the continent, and those are samples of medicines from Uganda that have been reconstituted at the at the Hospice Africa Uganda. And in Uganda, we also have the first country where nurses who are appropriately trained are allowed to prescribe oral liquid morphine, but they are burdened, as you can see. We have another dilemma. For the cancer patients, as we've said, radiotherapy is a major modality for palliation, but majority of Africa, there is no access to radiotherapy. Over 30 countries have no access to radiotherapy. So the key challenges are financing, medicines. We have barriers to access medicines, few health workers, lack of policies in many of the countries, and lack of data frameworks. As a way forward, we are trying to engage governments to implement the PC resolution, focusing on their 9 roles, as well as the faith-based and other organizations, and engaging funders to include palliative care in their funding streams. But we need a Marshall Plan for palliative care in Africa, integrated especially in a universal health coverage scheme. Without that, we are very unlikely to see much progress. Thank you very much.